I'm really excited to be here in this fantastic panel where we have experts, international experts with us to educate you on WHIM syndrome and where we are heading in the field. My name is Jolan and I'm the Division Chief of Pediatric Allergy Immunology at the University of South Florida and also Johns Hopkins All Children's Hospital. I'm the Robert A. Good Chair and also Director of the Jeffrey Model Diagnostic and Research Center. And what really drew us to WHIM syndrome is an important collaboration that was brought up by the Jeffrey Model Foundation. They were hoping that we will help or expedite genetic diagnosis of WHIM syndrome in pediatric patients. And as you all know, we are in the era of newborn screening for kids. So we were very excited about this challenge of how we could find WHIM syndrome in young patients. And we will continue to go on that path. This syndrome is unique because it combines innate and combined immunodeficiencies, T cells and B cells. So we are very interested about the disease. And we would love to find these patients as early as possible to expedite therapy for them.
I'm a pediatric immunologist and professor of pediatrics at the University of Brescia. I started to work on WHIM syndrome just after the identification of CXCR4 mutation in these patients, and we started screening all the patients with neutropenia for CXCR4 mutation and collected a certain number of patients. Now we have about identified 24 patients from all over Europe, mostly from Italy. And we were interested in the mechanism of the disease and also in the clinical heterogeneity and the outcomes. I see that many patients may have a bad prognosis due to HPV-related disorders or lung diseases. So this is a great opportunity to discuss about them.
I'm a professor of medicine at the University of Washington in Seattle. And I've been interested in the causes and consequences and the treatment of neutropenia for a long time. I think I saw my first WHIMS patient in the 1970s, but we didn't call it WHIMS then, we called it Myelokathexis because of the predominant defect that you can see easily in neutrophil development, and then the effete, the old-looking neutrophils in the bone marrow. In the 1990s, we studied the mechanisms of the disease in terms of biochemical features. And then early in the 20th or the 21st century, we began trying to find treatment. And I've had a long interest in basically helping patients, so finding treatments for rare diseases.
So just a few words to present myself. I am Jean Donadieu. I am a pediatrician and I am also a epidemiologist and working in Paris. I coordinate a French severe chronic neutropenia register. And inside this register, which is a national register, we follow patients with WHIM syndrome. And these patients are very rare. Even in the little niche of congenital neutropenia, as we have no more than, for all France, 14 cases. And but this group of patients is very special by many aspects of the phenotype. And so we have the occasion and several times to work on this little cohort, and to present also to publish the results of the series. Sarah, you know this pretty well. And so that's what I am doing, and that's why I may speak a little about WHIM syndrome.
We are fortunate to be the part of a consortium now when we have several centers working together to define the importance of early identification and key features. And I have to give the credit to Dr. Badolato. At one of our meetings, he was very astutely recommending that his experience in the literature is importantly seeing lymphopenia and neutropenia as a dominant feature of the disease early childhood. And we are putting our emphasis on these diagnostic steps, of course, additional clinical features to find these patients and expedite early genetic testing. So we believe that increased awareness between hematologists, immunologists, and even primary care physicians, just looking at the complete CBCs or blood counts and looking at the lymphocyte count and neutrophil count can bring these patients very early to us for genetic testing, and it's a key feature of the disease early in life.
Actually, the very real truth is that there are very limited options. The patients who develop HPV-related disorders, and that happens about 10, 15 years of age, in the majority of patients with WHIM syndrome, they can try to treat with a surgical option, with cryotherapy, or with immunological modulators such as imiquimod, but there is a very bad response to all the treatment. And when they develop tumors, I mean carcinoma, genital carcinoma, the only option is surgery. So that's the worst scenario that might happen for this disease that was apparently benign disease, but sometimes can have a very bad prognosis. And even now, when we know more about the pathophysiology, we know that we need a specific treatment to treat these disorders in the framework of WHIM syndrome.
The important part is to think about the chronicity of the problem, that is beginning in childhood, and then if the patient has no other complications, the things that happen much later in life. And because that's where treatment is really important for the very early stages of disease. The common thing in children is to have really bad otitis media. That's common in children, so it often goes neglected to begin with, but it so often leads to large perforations in the tympanic membrane and then ultimately to loss of hearing or deafness. The second complication that I think is really important to understand is the progressive pulmonary complications. The patients get over and over again what you might think is a common viral or perhaps bacterial respiratory infection, but over a period of years, they gradually progress to have chronic bronchitis and even bronchiectasis. So that respiratory insufficiency is common, and the early manifestation may just be getting out of breath or a little asthma. But over time, many patients lose respiratory function. And then the other problem is the viral infections. We see the warts commonly on the hands and feet, but it's the papillomavirus infection, particularly of the vaginal area and the cervix in women, that leads to carcinoma. And that's a very feared complication because, as Dr. Badolato said, this only real treatment is surgery, and it's, in the cases I know about, not very effective. I've been interested in the idea of targeted therapies for this very specific rare disease for several years. Probably 20 years ago, we began investigating drugs that block CXCR4. And then the pathway for development of mavorixafor is relatively long too, because the oral versions of drugs that block CXCR4 were known for several years before we got to the stage of clinical trials. And it was about 5 years ago that we actually began a trial, and only in the last month have we had a trial at the phase 2 level completed to show that the drug is, we believe, effective. That's a phase 2 trial, so there's not randomization. But the suggestive evidence is very good that a CXCR4 antagonist might be a specific targeted therapy to prevent infections, and we hope most of the other complications of this disorder.
I think that this, first of all, I think that the observation of this solid tumor in WHIM is something really new. You have to go back and to read very carefully all the literature to find this observation. And so it's not the first event which is recorded in the literature. And so you have to have a specific attention on this. But if you look to a cohort of patients, if you have enough time to follow them, you may observe that about, I think about 25% of the patients with WHIM syndrome will present before age of 60, so quite early in life, so will present a cancer. And this cancer will be first of all related to HPV, but they may also have cancer related to EBV, so it's a cancer related to virus infection, and HPV, EBV, and probably others. And so you have to check this time by time. I think that what is the most evitable cancer are HPV infection related cancer. So you have to manage this risk with time for the patient. So they have, for the women, they have to go to gynecologist, and but also globally you have to have this in mind. And so it's important to have this information and this risk in your when you manage the patient on the long term. So just to summarize, the risk is about, I think, at age of 50 years old, about 25% of the patients with WHIM. So it's quite a great number. Even if the disease is very rare, I think it's important. So I think we have observed two types of cancer, and I say we for our direct experience, but also when we read the literature. And if we look to all the cancer described in this population, I think we can say about half of the patients have HPV secondary cancer, like a vulvar cancer, or perianal cancer. So that's half of the patient. But there is also half of the patient with a lymphoma, or sometimes related to EBV, but not only. And what is remarkable, I think, for me, reading to all this literature, is that almost all cancer are on the mucoses or on the skin. So even for lymphoma, I don't know why, but you have to look for skin cancer, which is quite unusual even for lymphoma. So that's what we have observed. And I think just in terms of semiology, the skin cancer look very common on the skin. And so you have to take in consideration not very specific skin lesion, and to think about this, and to make a biopsy, or at least to see a dermatologist. A dermatologist should see such a patient and should have attention for this. Well, it's a complex, I think, because many organs or many infection or many disease may be observed in such patient and may impact on the quality of life and the life of the patient. And so if we look just on the cause of death, the main cause of death was, I think, 1/3 is cancer and 2/3 are infection. And if we look to the type of infection, it's more torpid infection, something not so exceptionally now, probably in developing country related to acute infection, but more soft or chronic infection like tuberculosis, like kind of hepatitis with we have one patient who died from atypical mycobacterial hepatitis. So something which can, in the general experience, look like heads, I think. So there is not massive infection, but many infections who are making well a difference in the life of the patient. They may also have some well, chronic bronchitis, which is also a cause of pulmonary insufficiency and maybe occasionally cause of death. So what is important is that this cause of death is early in life. What we can say early, it's between age of maybe 35 and before age of 60. So it's quite early in the life of what we could expect now. And so I think that that's the main target for any treatment we can have now, is to prevent this bad outcome.
I agree with Dr. Dale, who was actually emphasizing the importance of investigating respiratory functions. If you don't treat these patients early and appropriately, possibly with a specific drug, they might ultimately develop respiratory disease in terms of reduction of respiratory functions. In another neglected area is probably a neurological manifestation. Some of these patients may have limited ataxia, I mean, in terms of that is related to some malformation of the cerebellum. That's important to know for the patient. And the other area, but has been already put in evidence, is HPV disease, which has been very frustrating in terms of treatment.
When we talk about genetic diagnosis, I would like to emphasize that it is not only helping the patient, him or herself, but also their entire family. So it's not uncommon that by diagnosing a patient in childhood, you actually discover additional family members in the family at different ages suffering from complications of this disease. And we learned that through our natural history study in several cases. So that's one of the important matters, is that genetic testing and early identification can help the patient, but also several other members of the family. And on the second hand, what we learned from clinicians who have diagnosed patients early is that they could give better care for these patients regarding monitoring the humoral antibody response, checking the vaccine responses, immunoglobulin levels, and preventing the onset of infections that ultimately resulted in hospitalizations, ER visits, or as we heard from Dr. Dale, repeated tympanic membrane ruptures and hearing loss. So when we compare two groups, the patients who were identified very early versus the patients who were identified late, we were seeing a significant difference in their urgency of medical care and complexity of infections. So early diagnosis would basically bring the patients earlier to proper medical care and antibody replacement therapy, in our opinion.
The important advance, I think, really was recognizing it was a specific genetic disease due to a specific mutation that could be identified relatively easily with modern technology. The biggest problem in this field is probably diagnosis, recognizing the patients. And I think there must be many patients where the blood counts are not recognized as a signal to look deeper to try to find an immune deficiency and ultimately to make a molecular and genetic diagnosis. In terms of therapy, there have been important advances, and it was an important advance really almost 30 years ago that you could stimulate neutrophil production and deployment and reduce bacterial infections in a host of disorders associated with neutropenia. But what we realized over time was that the specific disorders like WHIM syndrome are not really just disorders of neutrophils, but they're truly immune deficiency disorders. And so it was with targeted therapy or the development of the CXCR4 antagonist, and specifically well-tolerated oral formulation of one of these drugs, that we see the greatest promise in terms of new therapy that will affect these patients, and very importantly, families of patients. If I could comment first, I'd say I'd like to know, is the problem, whether it's otitis or pharyngitis or cough, is it happening over and over again to suggest a chronic problem? And the first test I would do would be a CBC, a blood count with differential, to see if the white blood cell count total is very low. And the third thing I would do is I'd say, please help me to get a complete medical history in your family.
I agree with Dr. Dale. As a pediatrician, it might be sometimes a discovery, unsuspected discovery from a blood test of neutropenia or lymphopenia, even without symptoms, and then you have to investigate. If you see both, especially neutropenia, which is apparently very severe, you have below 200 cells, and the clinical manifestations are very mild. Especially if you see also lymphopenia, you have to suspect WHIM syndrome and then go for genetic testing of CXCR4. That is what I would do as pediatrician.
Yes, I agree both to Dr. Dale and Dr. Badolato that the CBC is a very, very important test. What I would like to add is to our allergist, immunologist colleagues in the audience is to always check the neutrophil count. We are focusing on lymphocytes. You have to check the neutrophil count and repeatedly check it. When both of them are abnormal, then you are beyond the typical antibody deficiency syndromes, and you really have to consider these unique entities such as WHIM syndrome. And we all know that Myelokathexis is a very important feature, but it's operator dependent and academic center dependent. So I agree with Dr. Badolato that going for an easy upfront genetic testing would be a very fast way of understanding whether the patient has WHIM syndrome. All of these panels are not covering the region that we are interested in. And these are very important steps in your critical thinking about the patient as an allergist, immunologist. Now, if you are a hematologist, I encourage you to look at the lymphocyte count and not to focus on the neutrophils alone, because I see a lot of our colleagues in hematology sort of not following the lymphocyte count age appropriately. So that would be very important for both of these specialties.
Well, right now, I would tell the patient or the family that there's hope for a specific treatment. And if the patient were of an age for clinical trials, I know we've begun, I would ask them about their interest in a clinical trial.
It's very important what Dr. Derek was saying. At this moment, it's very important to treat all the infections as soon as they appear with appropriate antibiotic treatment, and possibly to prevent them. We do immunoglobulin substitution treatment, even if you don't see ypogammaglobulinemia. If we see infections that might be bacterially related infections, we might also think to treat neutropenia with GCSF. But this is the current status of treatment. Things might change quickly if we get a more specific treatment, such as an antagonist for CXCR4.
Yes, our experience is also that immunoglobulin therapy is of high importance. And unfortunately, insurance companies may not always support that, and we have to get additional evidence for low vaccine titers after repeated immunizations. But I would not stop advocating for the patients to get immunoglobulin replacement if the infections don't get under control. G-CSF has been used by some of the physicians that we heard from, and both of them are sort of band-aids for the disease. We are supporting the patient, but not really correcting where the problem is. So going with targeted therapy is our new and most important approach in patient care. Therefore, thinking about the clinical trials or the new medications coming down the pipeline are important to be advocating for.